We are the Center for Advancing Health Outcomes, research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
Hello, and thank you for joining us on this rainy day. We are grateful to be here on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. We would also like to acknowledge that our investigators and staff and those joining online live and work on other Indigenous territories across the province and country. The health inequities experienced by Indigenous peoples in Canada are directly linked to systemic racism and colonial policies. At Advancing Health, we acknowledge that research and higher education are historically connected to these discriminatory and exploitative practices. And while we have seen that it has the capacity to do great harms, we also recognize the potential of research to help guide us towards healing. With that in mind, I am so pleased to introduce Dr. Eugenia Oviedo-Joekes, a professor at the School of Population and Public Health at the University of British Columbia and a research scientist at the Centre for Advancing Health Outcomes at Providence Healthcare. She is a Canada Research Chair in Person-Centered Care in Addiction and Public Health and led the groundbreaking Naomi and Salome clinical trials, which brought injectable opioid agonist treatment to Canada. She obtained her degree in clinical psychology at the University of Cordoba, a Ph.D. in social psychology and behavioral sciences methodology at the University of Granada, and postdoctoral studies at the Andalusian School of Public Health. Her main research area is in public health and addictions, with a focus optimizing the uptake and effectiveness of innovative treatments for opioid use disorder and to support its expansion across Canada. Thank you so much for joining us, Eugenia.
Thank you. Well, thank you, Michaela. Thank you, everybody, and thank you for the people that is joining us online, which is a great way to participate in this hybrid models of participation that we all like. We are here today, looks like I'm going to marry somebody, but no, we're here today to talk a bit about accessibility needs among people with opioid use disorder and the intersection with disability. And this is truly a work in progress session. And I'm very, very, very happy to do this with a colleague of mine, Dr. Jennifer Gagnon. I know Michaela just did an acknowledgement of the land, so I join that acknowledgement, but I also want to always remind everybody that you might see myself and Dr. Gagnon today presenting, but nothing I ever do or present is my work. The work belongs to everybody, belongs to every person has left data from the ground, every person have analyzed data, every participant that have provided data, people in the communications team, people, this is a work that takes a lot of people to show the excellence and how we can move policy forward. So I'm grateful for being today being able to present this. In case you don't know Dr. Gagnon, this is very long introduction, but I will just wanted to highlight that Dr. Gagnon comes from the School of Journalism and is a long-lasting advocate for disability justice. And we joined paths when we saw that there was an intersection between disability and people navigating the substance use treatment system. And Dr. Gagnon has a very long trajectory working with qualitative data and also bringing disability justice theme and framework to the studies we are doing. And for that reason, we are very, very, very happy that she has joined our research team, a person with such an experience and very, very embedded and committed to the topic. So what we intended to do today is to do a brief introduction to the topic that I just did and present Mr. David Jamieson, that has been a client partner and advocating for people with disabilities and opioid disorder. Unfortunately, besides all the advocacy he does, he had an accident and he couldn't be today with us. And this also speaks about the theme that we're having today on disabilities, not a huge accidents, but are the things that happens with people that are navigating the intersections when we talk about, this is not about a medication, this is not about a disability, this is about the things that happens to people that if you don't have housing, or if you don't have food, if you don't have a work that adapts to you, then the minimal access even to a presentation can be absolutely cumbersome to you. After that, Dr. Gagnon is going to show you a bit about the framework of disability, and then we're going to talk about the work that we are doing and what we can't do with the work we're doing on disability, and that's the reason we are embarking in new endeavors with Dr. Gagnon. And to transition to Dr. Gagnon, she is going to read us a poem that David Jameson, that takes creative writing, that he will love to read himself, has done, and kind of highlights the topic that we are doing today.
Thank you so much, Eugenia. It's my pleasure to read for you the poem Anaconda by David W. Jameson. I've been slithering along the gutter, this decrepit version of my life. Now I am shedding my skin, being reborn, a new life, strong, free, full of hope.
Thank you.
Eugenia, should I put my slides up at this point?
Please go
Thank
for
you.
it.
Okay, so I'm going to go over sort of the broad disability justice framework in lightning speed. So if you do have questions, please hold those, or feel free, if you're joining us on Zoom, to put those in the chat. Disability is often understood through what is called the medical model. And the medical model historically originated with the medical profession. And to be clear, this isn't saying that disabilities and people who live with disabilities aren't real or shouldn't be diagnosed or shouldn't access treatment. It's instead speaking about the ways in which the medical profession views disability. With the medical model, then, disability is conceptualized as a medical problem that needs to be overcome. It sees the disabled body as being faulty and in need of repair. And it casts disabled people then as defects, those who should be segregated from quote unquote normal society. And it means that as a disabled person, you should be seeking cure or treatment to become as close to normal as possible. It means then that the problem with the medical model is that it sees the person as the problem. In contrast, when we work within disability studies, we often use what is called the social model of disability. And this shifts our perspective to argue that it's not actually physical impairments or mental health and invisible conditions that impair someone, but rather society and the way in which society perceives impairment and disability. From the social model, then, how society reacts to and perceives impairments is the source of creating disability as a social category and leading to disabling of individuals. The problem then is not the person or the disability, but rather the barriers that society creates. What we're talking about then is ableism. And with ableism, here I like to use this amazing definition by Talila Lewis. Talila Lewis defines ableism as a system that places value on people's bodies and minds based on societally constructed ideas of normalcy, intelligence, excellence, and productivity. These constructed ideas are deeply rooted in anti-Blackness, eugenics, colonialism, and capitalism. This form of systemic oppression leads to people in society determining who is valuable and worthy based on a person's appearance and or their ability to satisfactorily produce, reproduce, excel, and behave. With this then, I really want to emphasize that ableism is about determining value and worth based on these ideas of production, excellence, and behavior. And I really want you to hold on to the last point in this definition. You do not have to be disabled to experience ableism. Ableism is experienced by everyone, just like racism, sexism, or homophobia. So, what does that look like for healthcare? Well, disabled folks represent approximately 1 in 4 people in Canada, and yet less than 5% of all medical students identify as disabled. And when we look at healthcare professions, one example is how 80% of doctors believe that disabled folks have a worse quality of life. And we see often in healthcare a lack of accessible equipment, and we can highlight the ways in which some of the policies that we see in healthcare are themselves incredibly ableist. Think, for example, about triage protocols and pandemic guidelines that actively devalue disabled lives compared to the lives of non-disabled people. This then also leads to what we can see as a history of trauma and violence in which disabled people interact with the healthcare system. Think about how in BC, the healthcare system is often a source of trauma and harm. Institutionalized and systemic racism and bias are present in our healthcare system. There are many colonial and anti-Indigenous practices that characterize healthcare. We have often a harmful or even non-existent accommodations process when it comes to accessing healthcare services. Many disabled people also say that they feel invisible when it comes to healthcare treatment, and that they are rarely, if ever, consulted on decisions that affect them. We also have, related to disability, many risks and vulnerabilities around disclosure, as well as risk and vulnerabilities around disclosing other aspects of our identities. Many disabled people, especially in a healthcare context, also report having experiences of retribution when they put themselves into that necessary self-advocacy position. And we have, as we know, a healthcare system in crisis with a lack of resources, supports, and awareness. And these different impacts then often lead to a lack of autonomy and agency for disabled people to participate in their own healthcare decisions and within a healthcare system where non-consensual treatment and forced confinement remain realities. What we're talking about then is ableism and power. And this creates an incredible imbalance between disabled folks accessing healthcare and the healthcare system and providers. From the perspective of disabled folks, it means that decisions are often made for us, not with us. Think about how often our information belongs to others who can share it as they deem necessary. Think about how our accommodations are often determined by others who may have little or no knowledge of our needs when disabled people live daily with our bodies and our conditions. The voices then of disabled people are often silenced in favor of authorities. Think about the requirement for documentation from doctors, politicians, community, and advocates, and so on. And the impression that this often creates is that disabled folks are neither competent nor trustworthy. We are not leaders, we are not innovators. We are instead problems to be managed. A perspective that I really try to change by highlighting myself as a disabled scholar and person. When we make that important shift then to disability justice, it's important to see how disability justice challenges these ableist perspectives and inaccessibility. Disability justice makes the argument then that normal is not only a myth, but actually a tool of oppression and power. Disability justice then puts forward that all bodies are unique and essential, and that all bodies have needs that deserve to be met by society. Our complex bodies, then, are actually a source of our strength, our resiliency, even our creativity. And it also recognizes that all bodies are caught by intersections of gender, race, class, sexuality, citizenship, colonialism, and yes, disability too. The intersections then of capitalism and ableism also strive to make our current global system literally incompatible with life for many. And this is something that really excites me about the work that we've been doing with Eugenia, is challenging those intersections and the ways in which they impact disabled life. Lastly, disability justice recognizes that justice is a collective struggle for access and liberation. And I really want to emphasize that by saying that disability justice isn't a single issue. You cannot do disability justice or even accessibility without also centering intersectionality. Those intersections of race, identity, gender, sexuality, poverty, capitalism, and so on are all crucial aspects of disability justice. It means then too that reshifting that focus to seeing self-care and disability advocacy as self-preservation and yes, political warfare is essential. That, folks, is my part. I just have a slide up with my my contact information. I apologize if you're hearing banging. I have roofers doing emergency repairs, and I'll hand it back over to Eugenia.
Well, thank you so much. That's not all we are going to hear from Jennifer, because now in the next steps that we're going to do, we're going to talk a bit about the work we have been trying to disentangle together with Jennifer, and how this intersection that she brilliantly explains plays into this. That is, this is not, when we talk about treatment, you might have heard so many times before, this is not about a medication. Yes, the medication is a fundamental part of what we do, and when we provide treatment, but thank you so much. Thank you so much. But it's way more than the medication. So when we started this project, then it's a project with several objectives. And what we were trying to do, an overarching objective, is to inform, grabbing the perspectives, do quantity and qualitative studies and methods, the perspective of clients and providers on how iOAT is delivered to the person. We know that iOAT works. There is no doubt. Yes, it works. Yes. The thing is now how we make it work. Well, you keep leaving me. Don't leave me. How we make it work for everybody. You know, yes, we know the antibiotics works. Not everybody takes antibiotics in the way that people are going to get better with antibiotic. It was the same with this medication. So with this project, what we try to do with more innovative methodologies and more in-depth diving in is how can we make this treatment be integrated so people actually can access it. So we had several, this is some of the examples of the work we did. So we talked to providers. There was grounded theory doing work with nurses, because this is mostly a nurse-driven treatment. Crosstown Clinic was one of the ones started giving some take-home doses of injectable diacetylmorphine. So we work on that. We also, with people here from this house, with Nick Bansbach and his team, doing measuring preferences in a quantitative way, and we did reviews on all take-homes, not just injectables, to see how we can make the treatment more accessible. So then we've had, at the time of the study, there were around 180 people receiving iOAT on all BC, and that includes Kelowna that has 30. So, and we connected with 139 participants. And so this is, in one side, you have the diacetylmorphine, has used to come before, and then in that little orangey, is where there are 2 syringes take home that was outside of the clinic. In one hand, you have the medication inside this clinic, and the other hand, they have the medication outside the clinic. And that it was a small step for, why you keep doing this? Was a small step, but it was really very relevant, very big to make. And the most challenging thing, as you might believe, was actually to find a tall, little plastic orange cup to put that, to take it out of the clinic. One of the most difficult portion of moving the medication outside the clinic, which was really a lot of effort, but was the beginning of starting providing take-home medications for some clients. This is part of the work we did, not with CHR, but with SUAP and with people from this house, with the communications team. And this is how we started to see the disability narrative. And this, I started to reaching out to Jen. This was when we started looking at caries. We had the narrative about people deserves to have their medication in the way they want to access it. And we have, people have the right. And one of the things we saw is, this was like, although we had that perception, but it was too powerful in the moment, seeing how difficult in terms of accessibility needs it was to get 3 times per day for people to the clinic. And it was not just about the freedom to take the medication with them from the perspective of human rights, in terms of, I don't have to go to the pharmacy daily to pick up my medication for my chronic headaches. I get a medication for 3 months. This is about seeing folks in the very crowded downtown east side in wheelchairs or scooters trying to move around to get to their dose. This is about folks with anxiety, panic, trying to make to their dose and not being able to have to choose between one or the other. Do I cope with this, or do I get to my meds? Because the only option you have is to pick up your medication, because injectable is not allowed outside of the clinical setting. So listening to Jennifer, Dr. Gagnon, you get fired up on disability justice when you see your folks that, hey, why X and Y didn't come for an interview? Well, they cannot cope with the stress of the crowd. No, what happened? Well, it's too in pain to make it today. These things really fire me up, and that's the reason I reached to Jen. And that's how, working in this other project, we said we need to do more. We kind of were a bit late to the party to do a total new project. So we added only one question in the way we could, and we added a question, do you identify with the description as the, how the Accessible Canada Act defines disability. And Jen was not happy because it's not the greatest, but it's all we could do in the moment. And if you were paying attention, I hope you did, on how Jen was describing the medical model, this definition feeds into the medical model. When you are impaired, when you cannot do something, so right away, you are going to just be marked by the system as a person that is missing something that the others don't. But having not a better standardized way of asking, we ask people, and besides, your substance use disorder, I don't like that word, but that's how it's classified nowadays. Do you identify with anything as above? And 115 people of the 139 said yes. We knew it's going to be high. We just didn't expect that it was going to be that high. So When we looked a bit into the literature, did not come after that as a surprise, looking into the US data to see that if, people with that are on disability in Medicare were 4 times, almost 5 times more likely to have an overdose rate if they were in disability than if they were not. And the most commons were psychiatric illness, chronic pain, and substance use. And those people have 24 increased rate in overdose, if you put all those things together. So definitely, disability intersects with substance use. And we ask our folks the list that the Canada Act gives you. And regardless of which one is the highest, the point is each of them was, this is killing me, each of them, somebody classified on each part: hearing, pain-related, mobility, developmental, dexterity. People had several disabilities, not just one. And of course, you will notice, I don't have a pointer, neither I bring one, very well prepared, sorry about that. But of course, you can see that mental health and pain-related and mobility are the biggest ones, as we could expect. But let's take a second. We are so used to the pain and suffering of and we are so used to work through the urgency of the overdose that we forget. And we have so many people saying that they have a disability related to these particular examples that we give here. So this is as far as we went, and besides all the work we have done in areas that are not disability. So with Jen, I will ask you to just show in camera if you can. We start looking at the socio-demographics of our folks, the people with and without disabilities. And there were things that we were expecting to see, and such as, for example, we expected to see some relationship with gender that we didn't see. And Jen, if you want to chime in on that, what you thought we would see some relationship on gender?
Yeah, so, I'm happy to also self-disclose, like, I'm a member of the chronic pain community. And one of the things with the chronic pain community is that women are actually very overrepresented. So we know that specific to pain conditions, women are often more represented in higher numbers than men. And we know that with disability in general, more women often self-report being disabled than men. So to take a look at this population and see that we have such a high rate of self-identification with disability, but we don't have those really significant gender divisions, is actually really fascinating. And I think it shows how intersectionality here, especially those intersections related to class, race, indigenous identity, housing, poverty, are actually really, really significant in understanding the access and disability experiences of this group.
Thank you. We had, of course, when we look at the substance use, we look specific at opioids, because we had a group of people that might have not been in treatment. And it's not, again, we are not looking for the surprise factor here in terms of, of course, they're going to use more opioids for pain that people not. But let's just remind all of us that we don't manage very well pain with opioids, and that the treatments available to manage well opioids are extremely expensive. So this is other areas that with Jen were like hurt, to say the least, on the very big difference between the people that are prescribed opioids for pain and people that are using non-prescribed opioids. And another thing that we here, particularly when we talked with the people that are lifting data from the ground, and when we do a knowledge translation, is there is a lot of people that they don't think they're coming because they have an opioid use disorder. They think they're coming because they have a pain problem. And I have spoke with people, for example, when I went in Kelowna, that they have a physiotherapist on as part of their team, and of course it's always busy, that you will see people that has been over the years hit by cars, or have been, because they are street-based, and then sometimes they're dosing, and they do not do rehabilitation, so they ended up with a posture very curved and they need and they are in pain, but not is the pain is related to the accident they had 3, 4, 5 years ago, and they have never done rehabilitation. And you listen to the participants, and they will not acknowledge any substance use disorder problem. The problem is the pain, when we do know that the medication will definitely not help them with that particular pain itself. So that I'm not sure if Jen, if you would like to add anything on that sense.
I mean, I think it is something where it's one of the reasons that I came to this research, is because I see so many of these statistics that show that the response that we have towards opioids and addiction is so closely tied to what I see as the bigger crisis, a crisis of chronic pain. As a healthcare system, we don't do a good job of supporting people who are in pain or treating and managing chronic pain. I recognize that I'm a very privileged member of the disabled community. I'm a lecturer at UBC. That's a position of privilege. But I essentially have untreated chronic pain because the healthcare system doesn't have the capacity to be able to support and help someone with the types of conditions that I live with. And so taking a look at this and seeing how many people say that their primary issue is not addiction, their primary issue is chronic pain, to me isn't at all surprising. To me, that speaks to how widespread that chronic pain crisis is, and the failures that we have as a society to recognize the severe impact that pain has on people.
Thank you. I think this is because I want to leave some space for some of the questions that people might have. We, of course, again, the expectation is that people are going to have poor health, but there was some insights that we took about relating to the injection-related problems, and some of the conversations we have with Dr. Gagnon on what the law here in, I think in Canada, certainly in British Columbia, does not allow and the healthcare staff to help a person to inject, only intramuscular. It's different in other countries. So imagine if you are a person that have a problem or a disability, cannot move, it will be very difficult for you to self-inject. And Jennifer was making the case in other areas of disability justice that also have similar issues. Jen?
Yeah, this is something too that we see with a lot of different disabled communities struggle with. So for example, within the education system, there are a significant number of disabled kids who may require some type of injectable medication that can be provided to them throughout the school day. And yet, many of these disabled kids do not have a personal aide or a care aide who, in a school setting, is actually allowed to be able to help them with an injectable medication or to administer medication. And that creates a lot of access barriers and exclusion for disabled kids, where it's often meant that it has fallen upon parents to make themselves available to come in at a moment's notice in an emergency situation to be able to administer medication that their child needs. Or if they aren't able to access somebody who can provide medication in the school during the school day, it also often means that disabled kids are actually excluded from being in that educational setting. They often have to stay home or pursue homeschooling because they do not have someone who is authorized to be able to administer medication to them.
Thank you. And our last exploration in our work in progress, we have this questionnaire that we pilot. It comes from a screening tool about structural vulnerability. And in this one, one of the things I want people to remember is our participants live are in difficult position in life. When we ask people, do you have enough money to meet your basic needs? More than half says yes, or sometimes. I just take maybe you can take a second and think what that will mean. Maybe one of you have ever been in that position and you can remember how that feels. It is a difficult. Those are difficult times, and sometimes those times are at a lifetime. And on top of that, the people that are self-identified as a disability had it worst. And while we expect those things to be more difficult for if you have to face a life with all the problems of people with substance use disorder, but now adding a disability, there are things that we think as a system we are doing well, like government assistance or accessing legal services, and we are not. And Jen had some clarifications to me and to the team on why we are not doing well on those fields in the system. Jen?
Yeah, I think it's really important to take a look at what barriers disabled folks themselves show as being most significant to something like employment. So, for example, many disabled people will actually say that the structure of provincial PWD, person with disability payments, is actually the most significant barrier to them accessing employment. These payments are often structured in such a way that if a person earns above a very small amount of income, their benefits from the province actually get clawed back. And it often puts disabled people who genuinely want to work and can work in the position of needing to refuse additional work hours because it would impact their PWD payments, and it could also adversely impact their access to some of the extended medical benefits that can go along with that. I think that's also really significant because another thing that we talk about with how rates are structured is that many disabled people actually don't have marriage equality in Canada, where if two disabled people get married, they are considered to be in a spousal relationship, and that also results in a reduction in their provincial PWD payments as well, meaning that for them to retain their benefits, it is actually better for them to not be married and not cohabitate, which denies marriage equality. So I think it's really interesting that, many folks may assume that addiction and substance use could be the biggest barrier to employment. And yet I think if we spoke more deeply with this population, they would actually identify many factors related to ableism and policies and structures that are much bigger barriers for them in accessing employment and income.
Beautifully said. So we are reaching the end. This is a penultimate slide. I know that word exists in English. So what are our next steps? So with Jen and I, we're working in this research question because one of the things we saw is in the way we have the data right now, there is a lot of questions that we cannot answer. So we want to explore the intersections with disability and how current and former clients experience accessibility and perceived treatment delivery that can support equitably, oh my God, equitable access. Sorry, my Spanglish. And we don't think in terms only about iOAT, but we think about diversified opioid prescription because people move around treatments. So this is applicable to any form of opioid agonist treatment. Last year, we got bridge funding, and we are reapplying for CHR. And the core of the work that we are trying to lift from the ground with Jen is making awareness. One of the things that she said in the minutes you were talking is we lack awareness. I can't do much about the funding, but I think we in this group, the people that are listening, and we can do about awareness and think about that an accessible services is one that can be used by all, not just by people with disabilities. And anybody, you don't have to be disabled to have been destroyed by ableism. And we can use the disability justice framework to make this word slightly better, particularly for people that already have it really, 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 really hard. So yeah, that's our work in progress. This is some of our participants. Some of them are with us, some of them are not. This is the work of the communications team led by Michaela that has been very well received by Health Canada. And so thank you very much. Jen, some few last words before questions.
I think the one thing I want to say is to really remember that disabled people, myself very much included, we are not our diagnoses. And to really challenge the assumption that to live with disability, especially severe disability or health conditions, means to live a life where your quality of life isn't as good. One of the most powerful pieces of research I encounter working in the disabled community is how healthcare providers routinely underestimate the quality of life of disabled people, and that disabled folks always say that their quality of life is so much higher than healthcare providers often assume it would be. So really recognizing that our diagnoses don't define us, but the ableist barriers that we do face in terms of being able to access the world accessibly or use flexibility and have options in how we do tasks or live our lives, those barriers really do have a big impact on the ability for disabled folks to not only manage our conditions, but to be able to be included and participate in the world around us as well. So ableism, I think, is a much bigger barrier than any impairment we live with disability.
Okay. Thank you. Thank you very much. So if you have any questions, we're here. Okay.